Yes, first thing, I need your patience because I'm not an expert in what you are doing. As Alexia said, we are working somewhere between real world evidence and decision support in real time and the research as a basis of this. And I will try to give a short overview. So I think the main things to say in advance is I will try to give you an overview. I will start with an introduction, give you an overview about the modeling methods and our model, on data limitations, and then more or less on the applications and results. So as this is a key lecture, I will be so unpolite and will not go into detail. I decided to give you more an overview on different applications because I think this would be interesting. And I, of course, try to cite all the sources and the literature where you can find the things in more detail. So the first thing is I shouldn't be here from a scientific point of view because, of course, at the moment, all our publications are under progress. They are only preprints, what we've done about COVID. That's also the reason because we are not focusing on these fast and quick publications. They are all the publications I will cite and will give the resources are preprint, so that's a disclaimer. But of course, and Alexia mentioned it, we started pretty early to focus different questions. So for example, what modeling types we should use, or we started very early to define a generic population concept for agent-based and other modeling techniques to model the demography and the population networks. I won't go into detail, so there were a lot of things. Of course, I have to mention the ongoing research projects. We have several research projects at the actual moment, starting from the actual prognosis for the Ministry of Health up to vaccination strategies. I will emphasize this later. And last but not least, as an introduction, I have to thank and I want to thank all our funders. It's the FFG, it's the WWF, it's der Medizinisch-Wissenschaftliche Fonds des Bürgermeisters der Gemeinde Wien, the SMDM, the FWF, and also European projects where we get our funding. And of course, our colleagues from different stakeholders like the National Public Health Institute or the Ministry of Health, or various counties in Österreich like Niederösterreich and Vienna. So what is the basic question? So I want to start. The basic question is we have the actual situation of the crisis, and this was the status at the beginning of November. And what we normally want to do is in a very urgent way to say, okay, what will happen under given measures in the next future? And you can see this was the prognosis. I think it was at the beginning of November, but that's not the only thing we're focusing on. The second thing is we try to focus on the dynamics behind the whole thing. So the dynamic is the development of symptomatic, unconfirmed patients, presymptomatic patients, and of course the unconfirmed cases, the asymptomatic cases. And so that's the big thing for us, and we have to do it quick and dirty very often. And the idea is how can we do this in a more or less professional and evidence-based way. So the idea is that we have, for example, Vienna, and we have an agent-based concept. So if we have an impact in the city of Vienna, we get contacted at working places or at leisure time or other areas. And then we have a transmission process with the following effect. So what are possible modeling methods? Probably most of you know, we can differentiate between data-driven models and causal models. I don't have to go into detail, of course. Data-driven models will try to fix with statistical methods or other processes to reproduce the scenarios we have. And causal models can be separated into macroscopic and aggregated models with a classical SER strategy. So we have susceptible persons, infectious persons, and resistant persons. In this case, we would need more of this because we need also the exposed persons. And then The story continues, so macroscopic processes will result in, let's say, for example, SAER-X models, where you have also the home quarantined hospitalized. So our approach is pretty well known in this community. It's a macroscopic model. It's an agent-based network model, where we start and to implement different agents with the different status. So we have the separation between different modeling methods. All of them have advantages and disadvantages, with different model features, with different possibilities of parameter integration, and different validation concepts. Most important things to analyze are always model-driven errors and data-driven errors, and I will try to focus in the next minutes on these aspects, what advantages and disadvantages we have using agent-based network models. So the basic idea to use the model concept we use is based on the international guidelines by ISPOR and SMDM, the Joint Modeling Good Research Practices Task Force, where our question asked, like, what is the concept process of the model? What is the dynamic transition model you use? What are parameter estimations and uncertainty? And how is transparency and validation? Of course, we are not the only one using it. Like, for example, we have more or less comparable processes in Australia or in Great Britain. And I will mention this a little bit later. So the idea to use agent-based modeling is not too far away. As we also described in our recent publication by Florian Miksch in our group, why should we apply ABM for decision analysis for infectious diseases, which we made on the example on dengue fever with colleagues from Harvard and from the Philippines. So I will give you a very brief overview on the model. The basic idea is that we use a modular concept. So the idea is that we have modules in our model where we can reuse various of these parts, and so improve the quality and the time span we need to implement a model for a new application like COVID-19 was at the beginning of this year. So first of all, we have our population module, which is responsible for creating and managing agents from birth to death. And it's called, it was developed in our COMET project, DexHelp, and it's called generic population concept. Why? Because it's used for different applications, for different illnesses, for different treatments, and can be adapted not only for Austria, but also for other countries, and can include several changing data resources with different modeling concepts. To mention a few, we have an agent-based concept, we have a system dynamics concept, and we have a discrete event concept implemented. Basic idea is pretty easy. We have statistical representatives as virtual inhabitants, which are quite simple at the beginning. So we have only sex and age and some additional informations. But the big idea is, depending on the research question, you can add additional informations in detail as you like. So for example, the address or social demographic aspects, or informations on the health status or on the living status, and so on, can be introduced. Of course, for COVID-19, most important is the interaction on a regional basis and the pathway of patients, like we describe it, from birth to death, which is focused, of course, in COVID-19 crisis on the aspect from a few days, a few weeks, up to a few months, as long as the epidemic is modeled in the actual case. The model is representing Austria's population between 1998 and 2100. And in this case, it's an agent-based approach with very few properties. One important thing is that we have not the possibility to scale down to get good results. So we really have to compute 8.9 million Austrians, and we cannot reduce it like we can do it in other approaches. More or less, it's a discrete time model with time step of arbitrary lengths using continuous time aspects as well. And it's implemented in Python 3 and Java, so we are very flexible and quick. One important thing is the validation process, of course. With the additional data and information I will present, we have to do, of course, the same thing in a quick way, but the basic is the validation with the Statistik Austria data, where, of course, the concept is based on. One important thing was also implemented a few years ago. It was the geographic toolbox, so where we can randomly samples residences for individuals in form of GIS coordinates. So that's, of course, an important thing to have a highly realistic population distribution. It was done by this residence sampling algorithm and together with information from the global human settlement layer, we could implement the distribution of the population. So to give you an example, if you have here an equal distribution of persons over their Gemeinde and Bezirk, so the local area, we can improve this distribution with the global human settlement layer so that you can see here where people live. You can see the Alps, and of course you can see here in Vienna the Danube, to get a better idea where are the households, what are they doing, where are they living. So the idea is, as you can hopefully see, to be able to improve the quality and precision of the model as good as we need it. It's not meaningful to have a very detailed model if you don't need this information in other applications, but we are able to add on these population models any given information we can get from the data providers. Second area was also implemented earlier in the last years. It's the contact module. So the basic idea is that we have different areas with contact. So we have households, schools, workplaces. We also have, which is very important at the moment, Pflegeheime, so the areas where people, old people and ill people are have their treatments. And last but not least, we have additional area, which is the aggregated leisure time contact. So what is the idea? The idea is that people are living their life, going to the areas where they have contacts, and then we can implement this in the model. And the most important thing, what was used now pretty often, is that we pretty soon and pretty quick have the possibility to implement measures. So for example, the schools enables us to very quickly introduce, for example, the measure of closing different areas of schools, for example, like it happened in the autumn now, first with the older kids from 14 to 18 and then with the younger kids. So this is possible in our model. One important thing is that we have to be able to make assumptions on this leisure time context. One project we get pretty good information is the WWF-funded project Synthese von Krankheitsausbreitungs- und Netzwerkdaten für die COVID-19-Simulation. So we get information from mobile phone providers where we have region-specific distribution based on the mobile phone data, where we have the origin and destination metrics. So you can see this in the picture here. We can have an analysis, where are people going to having their mobile phone with them. And this gives us a lot of information on this leisure time context. So it's only one example. I will come to the data later on, which makes us able to parameterize these contact module network where we have based on socio-demographic information and the places of the contacts, this network. To make it quick, the third module, of course, was pretty new when we started in January. It's the disease module. It's not very different to other diseases which are spread like COVID-19, but of course, various informations for the progression of the disease were fully new. So the structure was here. The structure is that every agent has as his own discrete event simulator. So we have 8.9 million discrete event simulators. And you can see we have, of course, to parameterize these pathways of patients. And then we can, in the case of a given infection, modeling based on age-dependent information, the progress of the illness. Policy module as the fourth of our models is just to be able to have a timeline of events that works as the actual model input, where we have the setting and the lifting of policies for the agent-based model. So examples, of course, are closing of locations, testing, tracing strategies, increased awareness, and so on. One main thing, of course, is to have the calibration of our models. So what we in the first step always have to do is to calibrate the model. So the whole agent-based model every week, every day, if necessary, is calibrated to the historic known flow of the pandemic, with confirmed cases, with critical and severe cases in hospitals and ICUs. And of course, at this moment, we are producing also the additional dynamic information in this agent-based model. For example, the to be confirmed cases, the presymptomatic cases, or the undetected cases. So that's the starting point of our model where it becomes interesting. And of course, then we have to set all the given interventions and measures and policies at any given point which happened in the history. Calibration, it's from the publication of our project, is summarized, of course, for different aspects. It starts with the regional distribution of leisure time contacts up to parameters for the disease. So for example, the recovery time for home quarantine, up to the possible event timeline elements to adapt, for example, hygiene events and so on. It's all the time, it's a living document. So we have the publication, of course, but also we have the technical description on the TechSelf web page, where we all the time give an update of what happened for the parameterization. And last but not least, to run the simulation, of course, we need the input, initialization, and output. So for the model input, the timeline of policy events that changed will be integrated. Then the model initialization I described earlier with the calibration of the whole system, actually for both waves. So for the first wave in spring and now for the second wave in autumn is done. And the model output will be defined. I will come to it a little bit later on. So the question is, we have a lot of possible outputs based on the 8.9 million individual statistic representatives, and we have to decide what is the output we need. Very briefly, the design concepts are following, as I mentioned, very standardized ideas. It's about emergence, it's about sensing, it's about interaction, stochasticity, and the observation of the reports. I will go over this because of the time. And I want to give you a short overview on the data resources and data limitations. Most of you know this probably from the media. It's a complicated thing, so we need a lot of parameters. So that's one of the sensitive and challenges in our model, of course. We get a lot of information for different aspects like the population parameters, the contact behavior, the disease progression, the hospitalization ratios, and so on. What are the main data resources? Main data resources that we all know as the dashboard here in Austria. It's the electronic Meldesystem, the epidemiologische Meldesystem, where doctors and labs have to report positive cases. We have quite a lot of difficulties there because we have backdated data, so we need a nowcasting algorithm, and a lot of information are not up to date every day. So we have problems with the hospital and ICU staying, which should be integrated here. And for example, especially with the recovery date, when patients stay at home, it is at the moment unclear when they are healthy again. So a lot of evaluations are done every day on basis of this data. For example, the age distribution, which is very important for COVID-19. As we know, that the percentage of ICU usage is directly connected to the age distribution of the actual situation. So at the moment, for example, we have some problems that elderlies are not so well isolated, probably as it could be, because we have a lot of death toll at the patient homes. We use quite a lot of additional information. I want to give you an overview on the possibilities. So we use the GIS information of population I already mentioned. This is, for example, the mobility based on the mobile phone data in Vienna, and the change between the lockdown in spring and the normal situation. So the good thing of our agent-based concept is we can directly integrate this information without an analysis step between. So we can this source and destination matrices directly integrate in our model. This is how you look on it. If you have the Austrian point of view, light top side is before the lockdown in spring, and to compare it, it's in the time of the lockdown, the totally reduced mobility rate. Additional information are, for example, the DINÖ network, which is run by Medical University in Vienna, where we get from symptomatic patients at the doctors an idea how many persons are infected with SARS-CoV-2. And you can see here on the right lower side, it increased a lot in the week 45. So that's an additional information. I can continue, for example, the cluster analysis. So where happens and what happens is, and you can see here, might be quite interesting that the number of the not clear clusters increased after the beginning of October a lot, which gives us some idea of where the problematic situation is. I will jump over the next steps. Maybe it's important that we have to parameterize, of course, the pathways of patients. We have to do this with, for example, hospital data. And this can be increased also, which a project we start at the moment with, for example, given data from CTs at the hospitals, so we can integrate also information on the pathway of really ill persons based on their CTs, on imaging data of their lung. I will step over the early phase analysis. It's only about those aspects that we really had to react very fast. We started in January based on our population and contact network model, and already computed first scenarios when the first confirmed cases were measured in Austria at the end of February. And we said, okay, at the beginning of March, we already had the first measures in Austria with university closure. And you all know internationally and nationally, they flattened the curve discussion. So we were able also to reproduce this aspect with our quite complicated model. And it was very important to compare it with other approaches. So we continued then and started to work for the city of Vienna, where we computed worst case scenarios. So this discussion was how many hospital beds do we need in Vienna? And the result was that the city made plans for additional resources at the Messe Wien, and they really implemented. So the idea was to have just in case additional resources for not severe ill persons, but persons who have to be helped at the hospital. We can continue this. In Austria, the measures for schools and jobs closures and additional measures were done in the mid of March and continued up to the end of March, where the masks were set in Austria at the end of March. And the whole idea I wanted to emphasize is that the model and models in such cases have to be pretty flexible. So we started with very little information, continuing additional data sets and so on, and used the model step by step for different research questions. So starting from the calibration and the a priori analysis up to resource planning, and at the end of the analysis of measures based on pretty detailed assumptions. One important application for our model is the weekly short time prognosis. So we are in consortium with two other groups from the Medical University, Complexity Science Hub, and the Ministry of Health, where we do the actual prognosis for the Austrian Ministry. And you can see here the examples where we have at the moment the actual set measures which should work in the next time. So you can see here in the picture the prognosis, which is from 26th of November. The idea of the whole project is, and that's very important from my point of view, that we compare 3 independent models. So we have the agent-based model, we have an extended SCRX model, and we have an epidemiological clockwork model. We published this recently. It's at the preview at the moment, where we have the possibility to bring together these 3 independent modeling methods. We make the update every week, and we compute a harmonized prognosis up to the hospital occupancy with a stock flow approach, which is added to these models every week. So these are also results from the publications, and you can see we update every week and compute the actual development every week, and we prognose the resource need in the ICUs every week for up to 3 weeks in advance. And those are the results which can be seen in our preprint. Of course, model comparison is done in a lot of different ways, and that's very important in my opinion. We always try to compare our macroscopic and microscopic modeling methods regarding to different outcome measures. And of course, there are different international activities like the Society for Medical Decision-Making Model Repository, the ECDC project on modeling, or other initiatives, for example, in Germany and other countries. So to come to an end, some selected results. One important aspect, of course, is the evaluation of tracing. We started this in mid of April, and major outcomes have been that tracing is effective if disease is well contained. And too many new infections reduce effectiveness and increase the efforts for tracing. That's not so surprising, but unfortunately we had the results that we had now in September and October here in Austria. The problem that resources and digital resources also for the tracing came to an end. And so we started with the problem. We made this analysis and it's also in review at the moment, where we compared various approaches for tracing accuracy. Picture. We can compare the different strategies of no tracing and tracing, for example, in various areas. At the moment, we also started in Austria. It's very important because we start with mass tests. So it's also possible to introduce in the model these mass tests, where you can see here the comparison of the different number of persons who go to the test and the effects. On the left side, the effect on the development of the infectivity, and on the right side, also the result in quarantined person. And that's, of course, also very important information to get this. Another important aspect is evaluation of undetected cases. That's one point which is probably one of the biggest features in our model. So we can compute not only the future, but also the history with the dynamics behind based on some hypothesis. And we published this, and it's a very important thing that, for example, you can see it on the yellow curve, you have the actual detected cases, and that a lot of other dynamic aspects are beforehand and are already in the past when we have with the detected cases the maximum. One last example, and I will come to an end, is actually we're working on the vaccination strategies. So who should be vaccinated, who should be first vaccinated based on the different features of the vaccination, for example, the effectiveness for elderly persons and so on. So as one example of our projects, we did this and tested various strategies for the vaccination, and it ended with, I think we published as a report at the beginning of last week, where we have the batches of the vaccination. So for example, the first vaccinations for 200,000 persons and effectiveness on the different population groups. So these evidence statements are generated and are sent to the highest vaccination committee here in Austria. Unfortunately, at the moment, it's only in German, but it came out that, for example, of course, vulnerable persons and medical personnel should be vaccinated in the first step. The last example is we use our simulations as a resource for synthetic data. So the basic idea is we are good in modeling these agent-based concepts, but the idea is that other research groups can use our data for their research. And these are examples of a publication on this, where we said, okay, we try to recompute the scenarios and give them to the public. So the data set is published at Keynote in the first step for the first wave from March to July. But at the actual moment, we already work also on various activities to give the data in a more detailed way, so that, for example, we can provide really 8.9 million agents and their networks to other researchers. So one concept could be to make an analysis on the cluster development. So if you see the example here, this is what you would see in real world. So if you have the real health system and that what happens behind in the simulation. And of course, this could be a possibility for research groups, for example, who are working on the DNA sequencing to learn additional things. Future works are a lot of different things. Calibration and validation is always a question, model extensions, but also, of course, I try to point it out at the actual moment, it's very dense to work in it, and there are a lot of things we have to do in more detail later on with various outcome measures. And of course, this could be hopefully also interesting for demography and social sciences in the future. And so I come to an end. And of course, I want to thank my whole research team and especially the COVID-19 team, who are working at the moment really pretty a lot. And I'm very thankful to them. And we try to support what happens at the moment. And I tried to point out that that I think it's very important on the one hand to have the actual decision support, and on the other hand to stay on the basis of a real evidence-based and good quality research at the end. Thank you very much.